bleeding and what is lower GI bleeding, proximal and distal to ligament of treats. Small bowel bleeding is the term used when the gastroenterologist can find no bleeding source after upper GI and lower GI endoscopy. Obscure GI bleed is the term used when no bleeding source is found after entire bowel has been examined using all available techniques, right? So when we've done everything and we cannot still find what is the cause of bleed, we call it obscure. Overt bleeding is when you can see the bleeding, either hematemesis and melena, or it is visible, and occult is when you have to test the stool and see whether there is blood in the stools or not. So what modalities are available for GI bleeding? Both as radiologist and gastroenterologist, what is our total armamentarium? It's CT angiography or CT enterography. It's catheter angiography, nuclear medicine scans, colonoscopies and upper GI endoscopies. They do a lot of capsule endoscopies these days, and then a lot of push-pull enteroscopies also done to try and, uh, in our case, not do diagnostic stuff, but mainly to reach or biopsy something we kind of find suspicious. So the first thing we're talking about is radionuclide imaging. So there, it's done using tagged RBCs, and there is something called a time to positive, right? If you can see the RBCs coming into the lumen before 9 minutes, generally then you will get a positive catheter angiography, because after all, ultimately the aim is to treat the patient. And so the good thing about RBC scanning is it detects a very low rate of bleeding. It is non-invasive, and if your bleeding is very slow, all right, it's taking place over a period of time, it can still detect it. And it can also detect intermittent bleeding. Disadvantages are that if it bleeds, suppose at point A, and because of peristalsis, by the time you're imaging it goes down, you can get an improper localization. And you can't really do it on unstable patients because it takes time to take out the RBCs, tag them, and the whole study takes about an hour. Catheter angiography before MDCT was one of the major diagnostic modalities, and the detectable rate of bleeding is quite a lot more than RBCs, but you can of course intervene and do direct visualization of the vessel. The disadvantages is that, if your patient is moving with DSA, interpretation can become difficult. You may not be able to catheterize everything that you're catheterizing because variant anatomy may be there. And then the actual thing is, my colleagues don't like to go in blind and first do a first do an aortic run, then do a celiac run, then do an SMA run, and then maybe even do an IMA run. That's not something that is the current state of standard of care these days, and I'll show you how that works. Right? Now, CT is actually the workhorse, at least in our department and in most departments across the world, because of the new guidelines which have come in. We don't give any oral contrast. So there are two types of studies which will be performed. One is when your patient is actively bleeding, which is the best time to do it. And one when your patient is not bleeding. When your patient is actively bleeding, you don't do anything. You don't give any water. You don't give any contrast, right? You just do an arterial phase scan and a venous phase scan. And then, of course, you do thin MIPS and you do a sliding scale and try and see whether there is an extravasation or not. CT angiography generally we reserve for patients who are not bleeding. Generally, these patients will have already had an upper GI, lower GI, they won't have found anything. And we'll always like to do two phases, even with entro. The only thing separate we do in entro from an angio is we give neutral oral contrast to distend the bowel. So, where is CT in the management algorithm of GI bleeds? So, like I said, there is upper GI bleed proximal to the ligament of treats, and endoscopy is the modality of choice overall that is accepted everywhere. That if you can do an endoscopy for this patient, upper GI endoscopy, do that first. And then, if you have a negative endoscopy and the patient is still bleeding, or if you have a case that is post-op, or you cannot put in an endoscope, you cannot extend the neck, such patients you do a CT. Right. The other thing where you do a CT is where they try and put in an endoscope, or the bleeding is so torrential, or the patient is so unstable that you cannot do an endoscopy. So sometimes, at least in our practice, those patients come directly to CT. So here is a patient who had an endoscopy. Okay, they saw a small ulcer. The patient was bleeding, But they thought maybe there was a pseudo cyst or an extrinsic compression on the stomach. They couldn't figure out what it is, and it wasn't a very fixed impression, and this is what it was. It is a fat density lesion in the antrum of the stomach. Okay, so this was a lipoma, and there was a small area of ulceration, and this patient was actually bleeding, and they really couldn't make out why there was a small ulcer on endoscopy, and this is how CT helped. Right, so large gastric lipomas can ulcerate and bleed. This was an interesting patient. This patient was really bleeding torrentially, came to the emergency. He was a young patient, was sent straight to CT by the CMO. And what you see on the plain scan is some thickening maybe around the esophagus. And then on the arterial phase images, you can actually see contrast extravasating. That's the Ryle's tube. So this is contrast around the Ryle's tube. And as you go down in the next image, you can see that this actually looks like you've given oral contrast to the patient. Here is the coronal image, and you can see blood in the stomach. And there is extravasation of contrast, torrential extravasation of contrast into the lumen of the esophagus. And you guys can go ahead and put in your answers in the chat box. Always good to make it more interactive and to see what you would have thought. You can actually see blood clots and the stomach filled with clots, and that's why you see that this blood is not uh, settling down into the dependent region. So this patient actually had tuberculosis, and we've had a few cases like this where we've had lymphadenopathy around the esophagus or trachea, and sometimes it's spontaneous perforation, sometimes even after ATT, the perforation is hidden, and once the lymph nodes go down, the patient suddenly presents with a fistula or a tracheoesophageal fistula, in fact. So a rare case, but something to keep in mind in our country. Okay, so this is a very standard case. This patient had an upper GI endoscopy, was bleeding. I think they probably didn't go down, enough. Distally was sent from outside to our hospital, then had a CT. And the very nicely enhancing lesion, which is both exophytic and endophytic, a very classical appearance. You can actually see an ulcer at its tip, right? And very classic appearance for a gist. So gists actually bleed everywhere in the intestine. So it's one of the lesions that generally tends to bleed. So if I have a patient with a tumor and I'm trying to decide between an enhancing gist and an NET, if a patient has come with bleed, I generally favor gist as the diagnosis instead of anything else. They tend to be both inside and outside the lumen, especially the ones that bleed. And many times, if you look closely, you can actually see the site of ulceration. There's also something called wild type gists, which do not express the CD117s, and these do not respond well to imatinib. Something that I just wanted to put out there. And of course, you can differentiate, kind of think which are the more aggressive kind of gists based on imaging. Let's not go into that now because we have to do lower GI bleeding. So what is the role of CT in lower GI bleeding? CT is the king there. If you have a active bleeding in an unstable patient, CT angiography should be your investigation of choice. There is no question. And I think even the gastroenterologists agree. Everybody agrees. These are all the kind of guidelines which are put in there. Everybody says that if you have a patient who's bleeding and you want to bring them in, go straight to CT. Okay. ACR also lists catheter angiography as appropriate, but we really don't do that in most modern hospitals. Okay. If you have active overt GA bleed in a stable patient, so that depends on where the patient is going. Generally, if they go to the surgeon, they will send it to CT. If they go to the gastroenterologist, they will try and do a colonoscopy. So the problem with a patient who's bleeding and doing a colonoscopy is that your yield can vary from 42 to 90%. Unprepared colon, blood coming down your scope, it's very difficult sometimes to catch the site of the bleed. So uh, it's an institutional practice. A lot of people will do an colonoscopy if the patient is stable, and a lot of people will do CT. This is the British Society of Gastroenterology guidelines. So you know they are heavily tilted towards colonoscopies, okay, because they're gastroenterologists. So guidelines can also vary. This is something we should know, that guidelines can vary depending on whether you're a surgeon or a radiologist or you're a gastroenterologist or even an interventional radiologist, right? Something to keep in mind, and always best to kind of project what makes your specialty look good. So anyway, so if you have unstable GI bleeding, that is a shock index of more than one. That means your systolic blood pressure and heart rate, your heart rate is more than your systolic blood pressure, then you go ahead and do a CT angiogram. And according to the British Society of Gastroenterology, that if you have an ongoing bleed later on, you do a CT. Otherwise, you kind of just uh, treat the patient and go ahead and do an endoscopy. But if you go to the ACG and SAR consensus recommendations, which have been published in 2024, you should do CT angiography as a diagnostic study in hemodynamically unstable patients and could be considered as the first line in hemodynamically stable patients, because nobody wants to anger the gastroenterologist, because that's why we say could be. We don't want them to stop sending cases. CTA is not indicated as a first line test in patients whom bleeding has subsided. Okay, that's understandable, because if the patient is stable, he is not bleeding, go ahead and do your endoscopies first. You can prepare the patient. Now, why is CT angiography in the modality of choice? Because according to all literature, in lower GA bleeds, it's either good or it's great, right? It's between 90, 85 and 92% sensitivity and specificity. So you will pick up a large proportion of patients who are bleeding. And if you say that the patient is bleeding, according to these people, you will be right 92% of the time. In our case, we are right substantially more than that, because we like to be very specific when we are talking about bleeds. What can also happen is when you're comparing CT with catheter, uh, you may not pick up a bleeding point on CT, which may be picked up on catheter, not because there's a problem with the CT, but because time elapses and bleeding can be very, very intermittent. So that is something to consider, that you may not have missed the bleed. The bleeding may not actually have been present at the time of the scan. It's relatively cheap compared to whether if you want to do a video capsule or you want to do even an IR angiography. And again, it is not our practice to go ahead and do an intervention or diagnostic angiography if the CT is negative, and I'll show you the data on that also. So you can see the entire bowel, and you can see lesions which may not be bleeding on CT as well. In patients with lower GI bleed, CTA demonstrate not only the site of bleeding, but it can also show you the cause of bleeding. Okay? And it can help you to decide definitive management and obviate need for further diagnostic investigations. That just means that once you do a CT, you find something, you decide whether this patient now goes to OT, whether this patient goes to the ICU for conservative management, or this patient goes to the IR suite. Okay? So here is a patient who actually had an area of a vascular malformation or an AV malformation in the colon. And you can see early filling of the ileocholic vein and a large bunch of vessels supplied by the ileocholic artery. And that's to show you that none of the other veins are filled, whereas you can see early filling of the ileocholic vein. This patient was managed by embolization. Here is another patient, the 50-year-old patient. You can see high density suggestive of blood. So one thing you can do on your plain scans is look for the blood and see where the blood is starting from. And that should give you a clue on your CT as to where to start hunting for the site of bleeder. And when you look at the arterial, you see this crescentic shape of leakage of contrast, which increases. This kind of shape, and I will show you another two cases, is pretty consistent with ulcer related bleed, and there is something happening in the liver. So what do you guys think this is? Go ahead and answer. So you have a patient who has liver lesions and who has this ulcerative kind of extravasation pattern in the right colon. Okay, so what do you think this is? This patient was managed medically by these are amoebic ulcers with the amoebic liver abscesses in the liver. So this patient was started on metrogyl and stabilized with blood products and managed conservatively. Patient came out of it. On the other hand, this was a patient not yet discharged after liver transplant. You can see the transplanted liver in the on the right side, and patient started bleeding torrentially in the sense that there was a drop in hemoglobin, sudden distension of the abdomen, and again you can see this very ulcer type of bleed, very crescentic. You can also see that there is blood in the colon. There is blood outside the colon as well, okay, which is a bit ominous, which is telling you that bleeding is both intra as well as extraluminal. And then you can see these areas of bleeding, and along the medial wall of the cecum, you cannot see the medial wall of the cecum very well. This was mucormycosis, and this patient, in patients with transplanted organs, you can get mucor, and of course, you must have seen tons of these during the COVID pandemic. But this was our series actually published just before the epidemic of mucor came out everywhere. So this was mucormycosis. This is another patient has lower GI bleed, and what you can see is diverticula. So if you have diverticulae in the colon, you can also have diverticula in the small bowel, and you can have exactly the same kind of complications. You can have bleed, you can have inflammation, you can have rupture. And you can see again there is bleeding happening inside the diverticulum, and you can see the blood is not settling down, telling you there is a clot over here. Slowly, the contrast is filling the clotted area, and this is the intra photograph showing you the diverticulum. You can actually see another diverticulum. There were multiple diverticula, and this was the one that was bleeding. So another thing that CT can do is it can help you kind of target where the surgeon should go. This patient was managed surgically. This was an interesting patient. There was no history, came with GI bleed, and shifted straight to CT. We could see this sort of thickened loop. There was bleeding inside the loop, wondering what's going on. That's bleeding inside the loop. No real kind of clue as to what's happening. Look at the lungs, there are some nodules here. Look at the uterus, you see this lot of vascularity over here, this hyperdense area here. You can again look at the major vascularity here, and mind you, there is no history of pregnancy or any such thing provided. This actually was a very patient had an abortion, I think 6 to 8 months back. This was a metastasis of a choriocarcinoma to the bowel. So one of the spectrum of hypervascular metastasis to the bowel. Melanoma is one, and we have also seen HCC metastasizing to the bowel. Now, especially with um, the kind of treatments that you're coming in, the patients are surviving longer, so you get metastasis in weird places. So this was a metastasis to the bowel. Another advantage of CT is that you may pick up lesions which are not actively bleeding at the time of the scan. You can have tumors which have bled and stopped bleeding. Uh, you can have inflammatory bowel disease. So we have had all of these. But this was just an interesting case I wanted to show you. This was a 19-year-old male with lower GI bleed. Uh, Not bleeding at the time of the scan, therefore upper GI and lower GI were done. Both were negative, sent for CT. And this was a very tubular structure which appears blind ending. It is enhancing but not bleeding at the moment. Bleeding is seen as extravasation of contrast into the lumen. So you don't see extravasation of contrast in the lumen. What you see is this tubular blind ending structure in the right iliac fossa in a 19-year-old male. This was a Meckel's diverticulum. Now we have seen a fair share of negative Meckel scan, which is supposed to pick up heterotopic gastric mucosa. Whether it's because there is no heterotopic gastric mucosa or some other reason, I don't know, but we've seen a fair share of Meckel's which are not picked up on the Meckel scan. So if you confidently feel you're picking up a Meckel's and there's a negative Meckel scan, you can still tell the surgeon, like, I don't think that, this is negative. Go ahead and take a look again. Maybe put in a scope, right? Especially in the current, in a clinical context where you have an adolescent or a young child who has painless bleeding. So this is another patient who's 59 years old. He's a cirrhotic and had previous surgery. Any idea what this is? So I'll just show you what I can see. So there is blood in the colon, you can see this hyperdensity in the cecum, shown by the arrow. There is nothing much happening in the arterial phase, maybe some faint enhancement, but really not lighting up on the arterial. As we go towards the portovenous phase images, we see some enhancement here. That's a bowel loop. Okay, and then you can see there are kind of vessels which are extending here and out into the anterior abdominal wall. And there you see this vessel coming in and actually going from the superior mesenteric artery into the anterior abdominal wall. What do you think this could be? Have you got anything on the chat box? And of course, it's going through the bowel, right? That is how you are getting a GI bleed. This is small bowel, and the vessels are going through. These are something called ectopic varices. Okay, so if you don't have varices in the expected side, particularly in the esophagus or stomach, they are called ectopic varices. So there is a large list of why ectopic varices develop, but interestingly, they develop in patients who have portal hypertension and have had surgeries. So they will occur at the site of closure of stomas or stoma formation. And there is always a portal component, which in this case is our superior mesenteric vein, and there is always a systemic component into which the veins drain. In this case, it was the epigastric vessels, but it went through the lumen of the bowel. And you can have this in any case. You can have them in the duodenum. Even rectal varices are supposed to be ectopic, but they develop in very interesting places in patients who have had surgeries. So, in case you have, even if you have a patient who has a hepatic osteogeneostomy, for example, and has portal hypertension, you can get ectopic varices in the region of the hepatic osteogeneostomy. So, wherever you have a surgery. Right. Let's move on from that. So sometimes you can pick up multiple lesions with CT, not just the one, and you may have one which is bleeding and one which is not, and CT can help you to pick up those lesions and decide what to target. So here is a patient who has a fairly well-defined area of arterial enhancement, which kind of fades away on the venous phase images, which is why you need to do a good arterial. And you can see that there is this tangle of vessels with early filling vein as well. And the more astute amongst you would have picked up that there is another one, right? A smaller one there. So you can have multiple angiodysplasias. And although this did not help us to decide which to target, what it helped us in doing was that both lesions were tackled as once before the second one could bleed. This one. This was the one which was bleeding at the time when it's larger, of course, but this would have increased in size. And these are where we use the catch-all term called angiodysplasias, right? So before I get castigated for that term, uh, if you want, you can actually look at the terminology, etymology, and usage of the various terms in radiology in as relates to the formation of vascular malformations. You can have angioectasias, vascular ectasias, telangiectasias, angiodysplasias, angiomas, and AVMs. AVMs, we understand. Everything else, I generally tend to call it an angiodysplasia, which is a non-specific term for a small vascular lesion. And they tend to occur in older patients. And of course, they have an association with aspirin use and aortic stenosis. So you do pick these up. uh, this is something which is actually used in terms of osteoreferendum, and I was debating whether to show it. I thought maybe it's too niche, but you can use the term angiodysplasia or AVMs. AVMs are the terms we use when for larger lesions where there is not only arterial but also an significant early filling venous component. All right. Now, CT can clearly help to define the anatomy of bleeding vessels and helps in planning intervention. So a prior positive CT angiogram increases diagnostic yield of formal angiogram, and then negative CT portends a negative angiogram. Now this is institutional practice. It may vary with your institute, but this is our institutional practice, and literature kind of backs it up. Because in patients who are bleeding, you don't want to be mucking around trying to kind of figure out where should I go and which catheter should I use, and what embolic material now should I be using, and what is this blush, etc. So if we tell them that this is what we see, they are ready to do their angiograms, and they are able to plan their interventions in a much better manner. It is faster. They use less of contrast, and they even use less of radiation because they know what to do. So this is an article by Shukla et al. Where says that no catheter angiography is needed in patients with an obscure acute GI bleed and negative CT angiography. Right? What it basically means in simple terms is that if you don't pick up bleeding on CT angiography, it is very unlikely that you will pick it up on a catheter angiogram. And we just had a patient yesterday where there was a post-op GI bleed and we couldn't see anything on CT. They went in anyway because there was a lot of pressure to try and do something and they really couldn't see anything. Okay, so how do we help in deciding um, like how do we kind of help in the IR? So first of all, let's see what do you think is the cause of this bleeding. This is a plane. This is an arterial where you see this extravasation and you see this filling up on the venous phase images. These are the coronals. And what do you think this is? This is something which was quite unheard of when I was a resident, that this never happens to Indians. This is a bleeding colonic diverticulum. So diverticulosis and diverticulitis were supposed to be Western diseases. Of course, we see them more and more now in our practice. And the right-sided diverticular is supposed to bleed. The left-sided diverticular is supposed to get inflamed and rupture. This is just, that's not a rule. That's just kind of how statistics is. And what we do is when we can see extravasation of contrast, we go ahead and tell them that we can see it from the ileocholic artery. We can see it from the third SMA branch on the left. We can see it on the second. Then we can actually show them that it's kind of dividing here, go ahead into this one. So what it does is they are very, very kind of sure about where they're going. And here you can see this blush from the ileocholic artery. And we did say this is coming from the ileocholic artery. Obviously, it is the cecum. This was a little bit more difficult. Okay, so again, what you see is this typical ulcer pattern of bleed in an 80-year-old male who was actually related to one of our consultants. You can see there is extravasation of contrast in the arterial phase, which increases on the venous phase. And then we did tell them it is the last ileal branch, and go ahead and go into this one. And that is what, and you can see actually blood in the plain scans going up till the colon. Patient was bleeding a lot. That's the bleeder extravasation, which is increased. And that's them going into that branch which I showed you with a microcatheter, going ahead and putting in glue, right? So again, 88-year-old male bleeding really helped them to go in fast, look at what was happening and sort it out. Now, uh, all bleeding into the GI tract does not happen from the bowel, right? You can have lots of things drain into the GI tract. You have the pancreatic duct, you have the biliary tree. You can have bleeding from all of these areas which come into the GI tract, and then they can present as a lower GI bleed. So here is a 70-year-old patient who came with melena and right upper quadrant pain. You can actually see blood inside the lumen of the gallbladder. So I was debating whether to show you a post-op cystic artery blowout or a cystic artery bleed. Thought maybe it's better to show you something which is rarely seen and something we sometimes don't think of. We tend to think of this as sludge, but actually this is blood. And if you do an angio, you see this little nodular area of enhancement. Not a very good image. Patient was not very cooperative at this point of time, but you can see that little pseudoaneurysm arising from the right hepatic artery or the cystic artery branch. So a rare occurrence, but inflammation can cause a cystic artery pseudoaneurysm as well. Normally, it can cause thrombosis, but in this patient, it caused erosion of the wall and something we don't see every day. And that was a cystic artery pseudoaneurysm. Okay, so the inflammatory process can damage the adventitia of a branch, and that can cause thrombosis of the vasa vasorum, which can tend to lead to weakness, right? And so on and so forth. This is the theoretical aspect of how an RHA pseudoaneurysm can develop secondary to cholecystitis. Trauma is one thing where you can get hemophilia, right? So we do CT angios in patients of trauma who are not settling down and have GI bleeds. and most of the time you will have a big laceration and you will have some degree of GI bleed and you will have a lot of hematoma in the liver to point you in the right direction as to what is happening, and you know what to look at. But also be aware that sometimes you can have very tiny aneurysms which can occur in patients who come to you with things like liver abscesses. And this patient had intermittent GI bleeding, and of course everything was done. And because the patient was bleeding intermittently, you can see there is no dilatation of the CVD, nothing to point towards the biliary tree as being a cause. But of course, the patient had a abscess, so we were kind of focused on we can't find anything else. Let's look at this, and a tiny pseudoaneurysm there, which was also embolized. I think this case was also published by our interventional radiology department. And of course, no GI bleed talk is complete without bleeding pseudoaneurysms from the pancreas. So here is a patient who had an hyperdense, swollen-looking pancreas, and in the arterial phase, you really don't see anything much happening there. So you can see maybe a little sputter of contrast coming from the splenic artery, and you can see like a jet coming out from there, and that's the aneurysm actually filling in a little later because the neck is so narrow. And that's a huge splenic artery pseudoaneurysm, sorry. And how would this go into the GI tract? You can put it into the chat box, and there is a particular term which is used when there is a bleeding which goes from the pancreas into the GI tract, and it goes through a particular anatomical channel. So put it into the chat box, and your registration for the next ref webinar is free. It's free for everyone, but it'll make you feel good. All right. So do remember that sometimes the bleeder may be seen not only in the arterial phase, even though it's huge, it may be seen predominantly in the venous phase because the blood takes a bit of time to kind of pool, and the actual defect may be so small or the pressure from the hematoma may be so large that you may not get a very good arterial filling on the early arterial phases. So post-op cases is again something where the patient has had a surgery, patient has now started bleeding, and CT is generally, nobody would like to do an endoscopy on these patients. CT is generally the first modality of choice. Something that is spoken about not as much as it should be, that CT should be in patients who have bleed, and nobody is actually written too much about it. That in post-op patients, usually if there is bleeding, CT is angio is what we go for first. And here is a patient who had Whipple's, 56-year-old male. Patient had a lower GI bleed, not an upper GI bleed, although you can see a lot of blood in the stomach. Then you can see blood in what is the pancreatico-jejunostomy limb. Okay, there is blood refluxing outwards on the arterial phase images. You can see a pseudoaneurysm from the GDA or a GDA stump, and you can actually see blood being forced into the lumen of the PJ loop. And by the time the venous image comes, you can actually see the blood is coming out with so much pressure that it is filling the entire pancreatico-jejunostomy limb with contrast. So this is again GDA stump blowout or a GDA pseudoaneurysm with active extravasation. This patient was also embolized. Sometimes things are not that dramatic. This is a patient, she is post right hemicolectomy and had a GI bleed. And that again, the value of the plain scan showing you some high density in the anastomotic site. And when you do your arterial, you can see there is a small nodular area of enhancement going on there on the venous phase images. Around the clot, you see these patchy areas of enhancement coming in, which is showing you that there is active extravasation. And most of the time, these will turn out to be anastomotic site ulcers. This patient, again, because we said there's an anastomotic site ulcers, it was being kind of debated as what to do. But in these patients, who are easily accessible to colonoscopy, endoscopic glue injection is a possibility. So again, CT deciding, finding the pathology, finding the site, and then deciding the management. So they can develop at any anastomotic site, but very common in the ileocholic and anastomotic ulcer sites. Most of the time, endoscopic glue injection should be done. And if that doesn't work, then they go ahead and remove the stoma. Just a slide about occult GI bleed. Now, what happens when you've done when endoscopies have been done and CT has not been done, right? So what type of CT would you like to do then? So in these patients, generally what we like to do is distend the bowel with neutral contrast and um, do a CT with mannitol. And uh, we don't do a classical enterography phase where we do what is known as the enteric phase at around 40 seconds. We do a standard arterial and venous phase, and we go ahead and look for things like tumors. Now, just because you have a video capsule endoscope doesn't mean, and you pick up mucosal lesions very well on the video capsule endoscope, obviously, because it is right there next to the mucosa. But it is not good for submucosal tumors. We have seen lots of patients where submucosal tumors are easily missed, where the mucosa overlying is not abnormal, or there is a very small ulcer, then video capsule endoscope tends to miss these tumors, and it tends to miss small vascular malformations. And also remember that they are scrolling through the capsule as it goes throughout. So there is a possibility that you may miss a few frames. However, if you want to pick up mucosal lesions, small ulcers, aphthous ulcers, you can easily pick them up on the video capsule. So video capsule versus CT better for vascular malformations, and small submucosal tumors, video capsule better for mucosal lesions. And of course, most of the time, if we pick up something that they are not sure and they want to do a video capsule, they will ask us, do you think capsule retention will occur? Which means that we have to rule out any major areas of narrowing or any diaphragm disease where the capsule may get retained. Most of the time, there are complementary modalities. And if you have a negative video capsule endoscope, CT intro is done. And even if they have a positive one, unless they are absolutely sure of the diagnosis, they will actually do a CT to go ahead and see what the lesion is looking like. Okay, so this is a diagnostic algorithm for obscure gastrointestinal bleeding by the Japanese enteroscopists. Now, the reason I'm putting this up and not the Western guidelines is because the Western guidelines say video capsule endoscopy is better, but the Japanese are people after my own heart, and they say that both with occult and overt GI bleed do CT. So, like I told you, that whenever you're looking at guidelines, be sure what kind of people have written those guidelines. But of course, uh, on a lighter note, of course, this is the Japanese guideline, and they say that you should do CT before you go ahead and do a video capsule endoscopy or a balloon assisted enteroscopy. Okay, so what do you guys think this is? Of course, you can see there is a capsule here. So because I was talking about the capsule, I just thought I'd show you a case where a capsule was done, capsule was negative. And this guy is 44 years old. So what do you think this is? Am I getting something? So here is a right iliac fossa. This is not the cecum. Okay, so oh. So what this is a small blind ending structure again. And this, so sometimes when you have a clot in a bowel, remember you can have this kind of appearance where the clot is releasing nitrogen, and you can get this kind of mottled appearance. So this is a clot. This actually turned out to be a Meckel's, okay, because you could see a blind end in a 44-year-old male, yes. And then the Meckel scan was done, which was negative, but the patient went ahead and had a resection, and it was a proven Meckel's diverticulum. And this, of course, was not picked up on the capsule endoscope, just to show you that they can work in tandem with each other. All right, so my last few slides. What are the pitfalls of CT angiography? You look at hyperdensity to tell you that this is extravasation of contrast. So if you have hyperdensity, which is already present, patient has had tablets, iron, calcium, or you have lits, or you have a previous study, or you have even some fecal material which is refluxed into the small bowel, you can confuse it with extravasation, right? So extravasation ideally should increase from the arterial to the venous phases, and it should change its shape. That is how you say that this is extravasation. Patients with small volume intermittent bleeds or who are not actively bleeding at the time of the scan may have a negative scan. We have discussed this. Respiratory motion artifacts may lead to difficulty in interpretation of angiographic images. And you can always get edge artifacts, right? So patients who are breathing and patients who have air and some contents in the bowel at the edge, you get artifacts which, when you MIP them, they look very bright and they can look very much like extravasated contrast. Go ahead and look at your base images, thin images as well, to make sure that you don't make this mistake. What is our practice? Acute upper GI bleed is upper GI endoscopy, acute lower GI bleed unstable CT angio, acute lower GI bleed stable, bleed ongoing, we do CT angio, stable bleeding stop, generally we do an endoscopy, then if CT angio is required, occult GI bleed, upper GI endoscopy and colon, and CT enterography and capsule, we are doing more or less in a complementary fashion. And so to answer our question, where does CT angiography sit in the evaluation of GI bleed? So for upper GI bleed, it is used as a problem-solving modality after endoscopy or used if endoscopy is not possible. For overt ongoing lower GI bleed in both stable and unstable patients, you should consider CT angiography as the diagnostic modality of choice. For occult GI bleed, if it is not at the top, it is near the top of the diagnostic algorithm and it is competing with video capsule endoscopy. And if you are thinking that the patient may have either a tumor or stricturing disease present, then prefer CT over video capsule endoscopy. If you think the patient may have a mucosal disease like an IBD, probably your ulcerations, you can do a video capsule endoscopy first. Right? That's all I have for you. And 45 minutes, I'm available for questions if you guys want to ask me anything.
I was expecting that music at the end, which comes with "That's all, folks."
Yeah, I think that's copyright. Even I think this must be copyright, but it's just something that reminds me of my childhood. So yeah.
So true. But Samar, that was just phenomenal. And even when the time you said that this is not a great image, and then you showed that phenomenal MIP image of a pseudo aneurysm. I mean, how is that not a great image? That's like a
It's
phenomenal.
a little fuzzy. I like sharper images, but anyway. Oh, somebody's given me very nice comment. Thank you so much, Tapas. You're my favorite person. And somebody else has said great seminar, good cases. Thank you, thank you, thank you, thank you, thank you, thank you, thank you. But where is Hemosuccus pancreaticus? Oh, it's there. Yeah. Thank you guys so much for participating. It means a lot, and it